WTH with all of these fertility acronyms. I know they can be so overwhelming. There are so many. So we are here to break it down for you. I'm Kerry Kavanaugh. I'm a reporter and anchor at Boston 25 News. I've been there for almost 9 years. I am a mom to a 5-year-old girl thanks to IVF, and I'm a proud board member of Resolve New England for coming up on 4 years. We are so lucky to have a fabulous expert with us today to walk us through these acronyms. This is Dr. Ann Korkidakis from Boston IVF, and she's going to say hello.
Hi, I'm so excited to be here. I'm a reproductive endocrinologist at Boston IVF and looking forward to going through this list of acronyms today.
So anyone that's going through this process and is new to it knows that there is a lot to learn. It's very scientific, it's very complicated, and the acronyms can sort of help us break it down and understand it a little bit, but you have to know what the acronyms mean. And I personally, when I was going through my cycles, I found them very overwhelming, having to constantly like jump in and out of things I was reading to then look up what this means. So hopefully we're giving you a bit of a comprehensive list here. And let's just start where this starts, and that's with TTC. Dr. K?
Great. So TTC is trying to conceive. So it's essentially referring to a couple that's just starting off, timing things, having kind of regular and unprotected intercourse with the attempt of, achieving a pregnancy.
And of course, we know that this all revolves around our cycle, and that gets us to AF, and that is not the dirty one that we might hear sometimes.
So AF or ant flow, which refers to a period or a menstrual cycle. I don't quite know where that personification comes from, but definitely in the fertility world, we're not excited when Aunt Flo comes to visit.
Right, but we do have to know when she's coming to start our cycles. Some people might end up down either of these paths, very common, IUI and IVF.
Yeah, so those are kind of our two standard treatment options. IUI refers to intrauterine insemination. That's where we time a transfer of washed sperm. So the lab preps a sperm sample, removes debris, dead sperm, leaving a highly concentrated motile sample. And shortly after ovulation, that's placed through the cervix into the uterus. And that way the sperm has less of a distance to travel to meet the egg, fertilize it, and create an embryo, which implants in the uterus. It works really well for a mild male factor, for borderline semen analysis results. Also, we combine it with Clomid or letrozole in a medicated IUI cycle, sometimes for unexplained infertility.
And some people, they have to do this step before IVF. At least I know people whose experience was sort of required that way because of how insurance was set up.
Definitely. So each insurance company has its various requirements, but some do require that you undergo 3 to 6 IUI cycles before they would cover an IVF cycle. That's very right.
And that conversation we can have for another day because that is a lot of cycles to require. But in many cases, it leads to the need for IVF.
Exactly, which is in vitro fertilization. And that's just referring to taking gametes outside the body. So stimulating the ovaries, retrieving eggs, combining that with sperm to create an embryo. Then we grow the embryo in the lab for usually about 3 to 5 days. We can either freeze those embryos and transfer in a separate cycle, or we can actually transfer fresh right after the ovarian stimulation cycle.
And we're going to get to those acronyms in just a minute. But of course, none of this is possible without OBs and REs.
So to get to the point of an RE, you go through medical school, which is approximately about 4 years, and then an OB/GYN residency, obstetrics and gynecology residency, where you essentially learn how to, deliver babies, how to operate, do hysterectomies, oophorectomies, things like that. So all our REs are certified in OB/GYN, so we're certified obstetricians and gynecologists. But we chose after residency to take another 3 years to specialize in infertility. And that training consists of both clinical, but also research. We're expected to kind of contribute to the field in a certain way. And that's how we become reproductive endocrinologists or REs.
And we appreciate you greatly and deeply. So as a woman in particular, starting on this process, there's various levels and things that are occasionally checked for or flagged, including AMH and FSH.
Yes, a lot of acronyms in the workup for sure. Anti-Mullerian hormone, or AMH, is a hormone produced by the small follicles in your ovaries. And it's a way we measure ovarian reserve. There's two qualities of eggs. There's the actual quantity, the number of eggs in someone's ovary, but there's also the quality. Ovarian reserve really measures the quantity aspect, how many eggs a woman has left, which tells us about a reproductive timeline. It also tells us how they would respond to treatment. So anti-Mullerian hormone is one of those blood works that help inform on ovarian reserve.
DOR.
Diminished ovarian reserve. So that's kind of a natural progression.
Right.
Sometimes we see that in women with a low anti-Mullerian hormone or something low called antral follicle count, which is a low number of follicles in the ovary, that they have more of a diminished ovarian reserve. Usually that's approximately an AMH less than 1, but there's a lot of different criteria we look into. Again, that's just alluding to the quantity aspect of eggs, not to the quality at all. So sometimes if you have a diminished reserve, but you have a high quality, your chances could still be quite high. So we take really a global picture into consideration.
And
Go ahead.
no, that's a perfect point you were making there, because these can sound daunting. I think when people get these results back and they then go Google the results, and it's like, oh no, this is really low. This is really this or that. That doesn't necessarily disqualify you or negate your opportunities for conception.
Yes, I completely understand the kind of drive to research everything on your own. But honestly, everything would be discussed at a follow-up visit in detail in terms of how these numbers actually translate to success rates for you personally, and for your partner.
Okay. Another potential stumbling block can be OHSS.
Yeah, ovarian hyperstimulation syndrome. So that's one of the potential complications of IVF. Essentially, what it is we want to stimulate ovaries to produce a high number of eggs, but we also don't want to overdo it, because if you have overstimulation, you can have high levels of hormone that could lead to essentially leaky vessels, which means an accumulation of fluid in the abdomen, sometimes near the lungs, occasionally needs to be drained. Again, this is very, very uncommon, but it's one of the reasons we monitor patients so closely in IVF cycle. We want to check for signs of over response, taper down medication, use special protocols. It's why we have patients come in so frequently during a cycle to monitor. The chance of anything serious is way less than 1%, but that's because we pay so close attention to it.
Partners have to be checked in this process as well. And that brings us to SA.
Yes, I feel like sometimes the male partners do feel kind of excluded in these steps, but the semen analysis is one of the big components of the infertility evaluation. And it consists of 4 different components that the lab looks closely at. One is the volume, then there's the concentration, so how many million sperm per milliliter. There's the motility, and then finally the morphology. Sometimes in the initial assay, the values are a little bit borderline, and then we repeat because sperm parameters can definitely fluctuate over time, but definitely an important component of the evaluation.
And again, if there are issues with any of those 4 things you look at, they can be overcome.
Definitely. In fact, even with very, very low concentrations, we have now the technology through another acronym, ICSI, intracytoplasmic sperm injection, to be able to take an individual sperm and inject it into the egg. So it tends to overcome even kind of the more severe cases of male factor, which has been really a big stride in our field.
Yep, we are the parents of an ICSI transfer. For sure. Another potential stumbling block can be a syndrome known as PCOS, the acronym.
Yeah, so PCOS, or polycystic ovarian syndrome, is a really common cause of infertility. Essentially, to meet that diagnosis, you have to have 2 out of the 3 criteria called the Rotterdam criteria. The first of which is irregular menstrual cycles. The second is clinical or biochemical high levels of androgen, which sometimes present as excess hair growth, acne. And then the third criteria is polycystic appearing ovaries on ultrasound. It is a diagnosis of exclusion, so we do have to do other testing to make sure there's no other reason for irregular cycles. but it's very common. Fortunately, it's very treatable. There's lots of oral medications to try to help restore normal cycles in the PCOS population. And once we are able to do that, their fertility rates are just the same as the general population. So very common and very treatable.
So personal story here, when I was very, very early in my journey that led to IVF, and I was living in another state and did not have any insurance coverage to really even assess what was going on. A doctor I was seeing suggested, well, maybe you have PCOS. So let's put you on this, I think it was metformin. Here's all these side effects to maybe treat something that maybe you have. And I don't have that. What are the risks there of treating things that we don't even know if patients actually have?
Yeah, I think it's unfortunate. I think that when you're not in a mandated state and you're unlikely to have insurance that, covers fertility treatment, sometimes we consider, less efficacious treatment modalities. I think it's really important to do a thorough evaluation to make sure we clearly understand what's contributing to the infertility. And, sometimes we do extensive evaluation, it comes back negative, and about half of the infertile couples, they have unexplained fertility, no clear cause. But there's definitely clear evidence-based treatment for those individuals as well. So very important to identify a clear cause. I'm sorry you went through that.
Yeah, I actually never took the medication. I knew the side effects were the way they were described. They were not going to be suitable to someone who is a lot on the road and didn't have a lot of access to restrooms. I'll leave it at that.
Yeah, a lot of GI side effects, but metformin in an individual who's pre-diabetic or has severe PCOS can be very helpful, but definitely not a medication you would take without having those diagnoses.
Thank you for that. Once we go through the stimulating and the medications beginning, we're going to arrive at an ER.
Yes, an egg retrieval. Some clinics refer to it as a VOR or vaginal oocyte retrieval. It's part of the IVF cycle. So we stimulate ovaries to create multiple eggs, and then we go through a small surgical procedure to be able to retrieve those eggs. It's done under anesthetic, so patients, while breathing on their own, don't remember or feel anything. It consists of an ultrasound with a very fine needle that lets us drain follicles. Follicles are sacs of fluid with eggs in it. We give that fluid to the lab, they sift through it, and usually the day of the ER or VOR, you get an egg number before you leave that day, but it's part of the IVF process.
And then you touched on this before, but subsequent to that, we have ETs and FETs.
Yes, so embryo transfers, if you add the F, then it becomes a frozen embryo transfer. So once we have eggs, we combine them with sperm, we grow embryos, and then we can either do a fresh embryo transfer, meaning at the end of the IVF cycle, 3 to 5 days after the egg retrieval, we do an embryo transfer, or we can freeze the embryos and then in a separate cycle, do a frozen embryo transfer. Frozen embryos function just as well, if not sometimes better than fresh embryos, which is pretty impressive. But the procedure itself consists of essentially a speculum exam. It's done under ultrasound, so we can see where we're guiding the catheter. And the catheter goes through the cervix into the uterus, and we deposit usually one embryo at a time, in some cases two. Other than the speculum, most women feel very comfortable during this procedure.
I can attest that was one of the least difficult parts of the entire, it's emotionally difficult, but it's not physically strenuous.
Other than the full bladder.
That's true. There's that. Yes. And during that time when you have an FET, you can do, I believe, a PGT-A.
Yes, PGTA, pre-implantation genetic testing for aneuploidy. The acronym has changed over the years, but that's the one that we all have agreed to use at this current time. Essentially, it consists of testing embryos, usually at the blastocyst stage, which occurs about 5, 6, or 7 days later after fertilization. At this point, the embryos are hundreds of cells, and there's a cluster inside called the inner cell mass that becomes the fetus. And then the cells on the outside, the trophectoderm, become the placenta. We have the technology to be able to take about 5 to 7 cells of the trophectoderm and send it for genetic testing to see, is this embryo likely have the correct number of chromosomes or does it not? If it doesn't have the correct number of chromosomes, it's more commonly leading to issues with fertility, so not implanting, or sometimes an early miscarriage. It is a screening test, so definitely not perfect. There are some false positives and false negatives. It's also not indicated in everyone, but in certain patient populations, it can be very helpful as part of an IVF cycle.
So once the transfers happen, we have what's called the 2WW.
The 2-week wait. So that's alluding to the time between, even in kind of natural cycles, between ovulation and when you expect the first day of your next menstrual period, which is the appropriate time to do a urine pregnancy test, or a UPT, another acronym. And it defies all logic because despite it only being 14 days, it probably feels like 14 months. So it's important to consider keeping yourself occupied during that time. So weekend getaway, starting a new craft, a new book. Yeah, important to keep yourself busy and surround yourself with people that, fill your cup during this time.
That's a really important piece of advice there. Get busy, get to something, because the days don't go by any faster. Time is time. And PUPO.
Yeah, pregnant until proven otherwise. And that is essentially what you are during this 2-week wait. Until you have that pregnancy test, you assume that you're pregnant and you have to act that way in terms of avoiding alcohol, smoking, continue taking your prenatal vitamin. If you're prescribed luteal support in an IVF cycle, like progesterone and estrogen, make sure you continue with those because you are pregnant until proven otherwise.
And you can be proven one way or the other by POAS.
So pee on a stick, or a UPT, urine pregnancy test, those refer to the pregnancy test you can buy at the drugstore. And essentially what it's detecting is a hormone called HCG, which is produced by pregnancies. Usually the earliest you can detect it is usually approximately 14 days after ovulation, or about 10 days after transfer. So just keep that in mind. I think it's very natural to want to test early, but there is a high chance of false positive and false negative. So important to keep that in mind.
Hold on for those 14 days.
Yes.
Let's talk about PIO.
So PIO, or progesterone in oil, could be a very important part of a frozen embryo transfer. We have many different protocols for frozen embryo transfers, but they can be divided essentially into two categories. One is a natural cycle or modified natural cycle frozen embryo transfer. That's where we're taking advantage of a woman's normal menstrual cycle to thicken the lining, where a follicle is developing, it's making estrogen, it ovulates, and then that cyst that forms produces progesterone. So in these cycles, women are actually making their own progesterone, and we only supplement a little through vaginal progesterone. The other option is a medicated or programmed frozen embryo transfer, where we're essentially overhauling the cycle, giving high doses of estrogen, and there's no endogenous, so you're not making your own progesterone in that case. That's where progesterone in oil comes in. It's an intramuscular injection, usually given in the buttocks. It can be a little bit uncomfortable, but it is providing a high dose of progesterone. And studies have shown that in these medicated or programmed frozen embryo transfers, it actually improves the chance of having a pregnancy if you're taking the PIO at least every 3 days. So oftentimes it's incorporated into those protocols.
Gotcha. DE.
Donor egg. So that kind of fits in with the diminished ovarian reserve, or the DOR. In certain cases, through IVF cycles using your own eggs, we're not successful in being able to get a good number of eggs or good quality of eggs. Sometimes we consider donor eggs. That could come usually from a donor egg bank. And because we think fertility is so closely tied to the egg age as opposed to the age of the uterus, we use donor eggs. They have a high chance of success, kind of irrespective of age, about 50% per embryo transfer.
Wow, that's not bad. Dr. K, let's talk about HCG.
Yeah, so HCG stands for human chorionic gonadotropin. It's a substance produced by pregnancy. So it shows that there has been implantation. It can be detected either in a urine pregnancy test or through a blood draw.
Okay, perfect. Some difficult acronyms here, starting with RPL.
Yeah, recurrent pregnancy loss is one of the reasons that patients definitely come seek our help. It alludes to having at least 2 pregnancy losses. In the past, you would actually have to have 3 to meet that requirement, but more and more research is suggesting that it's worth doing some testing and potentially treatment after 2, because we do pick things up that we're able to modify and improve the chances of a pregnancy sticking next time.
And PUL?
That's a pregnancy of unknown location. So early pregnancy is such a hard period because when the pregnancy is very small and the HCG levels are on the lower side, it's really hard to know, is this a pregnancy that's going to continue on? Is it a pregnancy located in the uterus, or is it a pregnancy outside of the uterus, potentially in the fallopian tubes, alluding to something called an ectopic pregnancy? So in this early pregnancy period, when you have a positive pregnancy test, it is going up. Well, we can't quite see anything on ultrasound just yet because it's too early. We call it a pregnancy of unknown location. Usually over time, it becomes very clear. And a lot of these do continue on to be healthy pregnancies that end up in, babies. But the early pregnancy period is really difficult to be able to navigate.
Okay, and I know we said these are definitely not medical acronyms, but definitely used in this space and community. BFN and BFP.
Yeah, so BFN is a big fat negative, referring to a negative pregnancy test. I know some of my patients use a different F word in that acronym. Um, But obviously, an incredible disappointment. I think it is important to keep in mind that most of us have experienced a BFN before we've experienced a BFP, which is a big fat positive, a positive pregnancy test.
So, what is your take on all of these acronyms? Are they helpful? Do they need to be sort of visited with caution? What do you want your patients to take away from this, world of acronyms as we try to learn this complicated process?
Yeah, I think it could be definitely daunting entering these chat rooms in this space when you're not familiar with these acronyms. It could feel maybe sometimes isolating, and infertility in itself is so isolating. But over time, I think these acronyms, become second nature. You really are able to understand and navigate the space easier over time. It is also important from a medical perspective to make sure that these are kind of validated and well recognized acronyms. So we really are speaking about the terms and procedures that we mean to be speaking about. Sometimes there's overlap or miscommunication. So I think that they can be used, but obviously with caution, and explaining exactly what you're meaning with words is always helpful.
And hopefully, people, individuals, couples, families are coming into a space with the provider where they feel that they can go to them for some of these answers and explanations and information. And they're not just alone at night, doom scrolling on Google.
Of course. I mean, we have patients come to us and, talk about what they've read and learned in these social media spaces. And again, it could be very supportive, but sometimes it doesn't necessarily apply to that particular individual or couple. So I think our role is to kind of explain their journey and their process, and really what's contributing to their difficulty in conceiving. So making sure you run it by your healthcare provider and team is kind of important to make sure that you're on the correct path.
And of course, Resolve New England also exists for this very reason. They offer so many great opportunities to connect with community virtually, in person, events that we hold to bring people together. So there are people that can answer some of these questions too, maybe outside of a doctor's office as well. So please check out all the offerings that R&E has. There are so many out there and growing. So thank you to everybody for being a part of WTH with all these fertility acronyms. We did a little bit of a list here that we can share with everybody. I'm sure there are more that we missed. So please feel free to drop any questions you have in the chat, and we'll be sure to respond to you. Thank you so much for being here today, Dr. K. We really appreciate you, your time, your years of education and expertise.
Thanks so much for having me. And please send in those acronyms. I'm looking forward to learning new ones.
Everyone have a great day and good luck on your journeys.